Good evening, everybody. I'm Tom Whalley. I'm the director here at the Hunter Medical Research Institute, and it's my pleasure to welcome you tonight to what is the last of our series of community seminars run virtually in these difficult times for everybody. So there are over 400 people registered this evening, which is fantastic, and I'll talk more about what we plan for the future later on. So before we begin, I'd like to acknowledge the traditional custodians of the land in which we meet here at HMRI, the Wabakal and Worimi nations, and to pay my respects to elders past, present and future, and likewise to the elders of the peoples wherever you may be watching this from. So 2020 has been a year like no other, and one that many of us will be happy to forget in all kinds of ways. The challenges we've all faced have emphasised the importance of taking care of ourselves and of taking care of people around us. And that's particularly true with regard to issues concerning mental health. We're all aware of the impact that poor mental health can have on us as individuals, but also on the people around us. Now, there's been a stigma attached to talking about mental health issues, and that's limited the ability of people to actually talk openly and frankly about them, whether they suffer from them themselves or whether they're in the family. And that's limited people's ability then to get proper treatment and support for the difficulties that they're facing. So tonight's virtual community seminar, entitled Mental Health, Taking Care of Yourself and Each Other, will focus on what research can teach us about how families and friends who are caring for and supporting people with mental health challenges are affected, and why it's important for them to be able to talk about their experiences and to access support as well. We'll provide some insights into the programs that our researchers, that I'm going to introduce in a few minutes, have developed, as well as providing some helpful resources for the community around how you can find support for those living with mental health issues and also for those who have to care for such people. We're very lucky here in the Hunter to have world-class expertise and world-class researchers who can help us through this. So our current Researcher of the Year is Professor Francis K. Lampkin, whom some of you will have seen before presenting at one of these seminars a few months ago. But this time it's the turn of some of our colleagues in the network here in the Hunter who are going to share their valuable knowledge and experience around the work they do for the benefit of the community. We've allowed plenty of time for questions, so please send them in via Facebook chat or private message to us throughout the event so we can try and address as many of them as we can during the session, but we may have to respond to some of them offline later. So I'm delighted to welcome our first speaker here tonight. Our first speaker is Dr. Melina Heinsch, who's an accredited social worker and a senior research fellow for the University of Newcastle Priority Research Centre for Brain and Mental Health. She's a mental health researcher, and her projects have involved partnerships with leading government and industry and voluntary organisations, including Beyond Blue, the Mark Hughes Foundation, and the New South Wales Ministry of Health. Melina will be talking about the role that e-health, she'll explain that to us all, the role that e-health can play in supporting people living with mental health challenges. So I'll hand over to Melina.
Thank you very much, Tom. So as Tom mentioned, my name is Melina Heinsch and I'm a researcher at the University of Newcastle's Centre for Brain and Mental Health. Together with the second speaker for tonight, Dara Sampson, I work in a team that's led by Professor Francis K. Lampkin. And that team specialises in developing, implementing and testing digital interventions for a range of mental health challenges. I'm also a social worker with a background working in healthcare. So tonight I'd like to talk a little bit about the role that e-health can play in supporting people who are living with mental health challenges. Just by way of background, I'll just take a moment to remind everyone just how common mental health problems are in the Australian population. So in any 12 months, we get around 20% of Australians who meet the formal criteria for mental illness. And almost half of the population will experience a mental illness in their lifetime. Some of the most common mental disorders are anxiety disorders, which affect around 14% of the population, affective disorders like depression, and substance use disorders like alcohol dependence. So adding to this, during the height of the COVID-19 pandemic, evidence shows that rates of depression and anxiety doubled from 2017, with 1 in 10 Australians reporting that they felt depressed, and the majority of those people feeling so depressed that they couldn't be cheered up. So, caring for ourselves and for each other has never been more important than it is now. So in terms of treatment, many people who are experiencing mental health difficulties are unfortunately still disadvantaged by a lack of access to mental health treatment. So for example, in 2019, more than half of people who needed mental health treatment in a 12-month period didn't receive it. And that's despite considerable government investment into improving access to mental health care. So why is this the case? Why don't people access treatment? Well, there are a lot of individual and also broader structural reasons that affect people's willingness, but also their ability to seek mental health treatment. So in terms of individual reasons, people firstly have to actually understand that what they're experiencing does meet the criteria for a mental health problem. They have to recognise that there's something going on with them. They also need to be open to the idea that mental health services can actually assist them with their mental health concerns. And as Tom mentioned, there's still a lot of stigma in society about actually having a mental health problem. Things like time commitments can also really affect a person's ability to access traditional treatment options. And a lot of people still prefer to rely on themselves. I think a lot of us are inclined to think, I can do this myself, I don't actually need any help. But there are also structural reasons that can hinder a person's ability to access treatment. Mental health services do have limitations in the way that they can accommodate and support people, and referral pathways aren't always particularly clear, particularly if people are presenting with more than one condition, which is actually the norm. Treatment also might not be affordable, or geographical isolation might limit a person's ability to actually get into a clinic and receive treatment. There also might just not be a range of services that are relevant to a person's particular condition. And of course, during COVID-19, people's access to mental health care has been made a lot more challenging by social distancing requirements and also by lockdown periods. So how might e-health overcome some of these issues? And by e-health, I mean health and mental health services that are provided via the internet or the phone, like telehealth services, health-related apps on your phone, or internet interventions that are designed to be used on your PC or your laptop. E-health options could provide an important additional access point for mental health care. So I'm not suggesting that it replaces traditional mental health services, but that it can provide an additional point of care. The benefits of e-health are that it can be accessed by people at any time from the comfort of their own home, meaning that it can work around people's time commitments. Many e-health services are also anonymous, which can help people to overcome feelings of shame and stigma, which are really common reasons why people often don't seek mental health treatment. E-health is not only accessible, it's also affordable. Many e-health services are available 24/7 and are often free of charge. And because people can use e-health services from home, they also save on travel expenses. Another good thing is that e-health also enhances people's self-reliance, so it can give people a sense of empowerment and control over their own situation, and it can help them to develop coping skills. So for example, if you're using an e-health intervention on your phone, help is at hand all the time, and that can help you to feel more control over your symptoms. eHealth can also be easily customised for the needs of particular patient groups, and some of our other speakers tonight are going to be giving you some examples of how eHealth can be used for particular populations and particular issues. And lastly, eHealth also provides important opportunities for sharing and networking among people with similar conditions. So, for example, social networking interventions can enhance people's well-being and give them a sense of belonging with a similar group of people who share similar concerns and challenges. So, I think there is potential for eHealth to overcome some of the traditional barriers to accessing mental health services. And look, to finish off, don't have much time, I thought I'd provide just a few key tips for those of you who might be considering using eHealth services yourselves, or for those who might be thinking about referring a friend or a loved one to an eHealth intervention. So I hope that the following 6 tips might be, helpful to get you started. Number 1, does it work? If a program functions well, then people are going to be more likely to want to use it and also more able to use it. So a great place to start when you're thinking of referring someone to an eHealth program, be it a friend, a family member, or a client, is to just explore the use of the program yourself so that you can see how it works and what it involves. Does it work reliably? Is it suitable to the person's technological skills? And what devices does it run on? eHealth treatments are often delivered on different devices such as a PC or a laptop or an app on a phone. So we just need to make sure that it works on the devices that the person has access to. It might also be helpful to read some reviews about the program online or on the App Store to see what other people think of it. Number 2, find out who the program is for and who should not be using it. That might seem like an obvious one, but who is it specifically for? Is the program for people who are at risk of developing mental illness, or is it for someone who has mild to moderate symptoms? Is it age appropriate? Is it culturally appropriate? Not all mental health programs will work for everyone. Most of the time they've been designed for a particular population, like for example older people, young people, or people with a specific diagnosis. So it's important that eHealth programs are used by the people that they're intended to be used by. Number 3, check whether the program is evidence-based. Something to be aware of is that not all apps and digital health programs that are freely available are supported by research evidence. Nowadays, just about anyone can develop an app or a program. So it's really important that we're using programs and referring people to programs that actually have an evidence base and that have been tested to make sure that they're safe, appropriate, and effective. If a program does have an evidence base, it will usually include information about that within the program. Number 4, pay attention to how risks have been managed and addressed. The kinds of risks that people tend to be most concerned about in the eHealth space are things like privacy and confidentiality, which can be harder to control online. So a good eHealth program will address those issues and clearly state how it will collect, store, use, and protect the information that people provide. So make sure that the owners of the program have identified the potential risk of the program and that there is a privacy policy or a risk management procedure in place. Number 5, is the program self-guided or does it involve person support? And by person support, I mean either clinical or peer support that runs alongside the automated online or app-based program. So this kind of person support can occur in different ways. So it might be provided by a clinician, via email or phone, or in person in an online chat room. It might be peer-to-peer support that's provided via a social networking program, for example. And what we find is that programs that include a person support component are generally more effective than programs that are purely automated. So that's something to keep in mind. And the final thing to be aware of is whether you're referring someone to a free or a paid program. So if there is a cost, this could present a barrier to a person accessing the program. So it's always a good thing to check before referring someone. So I hope those points provide a useful starting point for those of you who are interested in trying out e-health interventions. And now I'm going to hand over to my colleagues who are going to talk a bit more about the different kinds of programs and supports that are available to ourselves and to our loved ones who are living with mental health issues. Thank you.
Thank you very much, Melina. And keep those comments and questions coming in, please. So I'd now like to introduce the next speaker, who is Dara Sampson. And Dara is a research manager at the University of Newcastle Priority Research Centre in Brain and Mental Health, and also a PhD student. She's a social worker by background, and her focus has been working across lots of projects, including the Family and Friends Support Programme, which particularly offers help to the family and friends of people with drug addiction issues, and also the Mark Hughes Foundation, working with the family and friends of people who are suffering from brain cancer. So Dara's presentation is going to focus on the research into the importance of supporting people caring for their loved ones suffering from mental health, what those outcomes of the research are, and what we can learn from that research. So Dara.
Thank you, Tom, and thank you, Melina. And thank you and welcome everyone joining us tonight in what is not only Mental Health Month, but actually is Carer Week. So it's particularly important to be discussing these issues with you tonight. I wanted to start off by setting some context around care, what it is that we mean by care, and who's doing that caring work. If we think about the concept of ethics of care, we think about care as a moral proposition, something we do as a humane society, and something that we should do and something we believe we should do. What does that mean in the Australian context, though? According to ABS data, we have approximately 2.65 million carers in Australia. They're the people who actually declare themselves as carers through census, but we know there are hidden carers, people who actually don't define themselves as carers, so in likelihood that figure is much higher. We also know through Carers Australia that the estimated value of care is $77.9 billion nationally in Australia. And that's what we know, again, without the hidden cost of care. So who's doing this care work? Again, according to the ABS, 70% of care work is done by women. And I've been reading some recent research around, and we're all, I guess, particularly interested in COVID and what the impacts of that are likely to be. And a term that's been collared called the pink collar recession. So we're likely to see, and we are seeing, more women who have moved out of the workforce because of their care responsibilities. And I think this is an important thing for us to be thinking about. And in that way, the nature of care is, and what is happening through COVID, is actually extending traditional care patterns. The second point there around the lack of long-term research. There is clear research about the importance of family and friends to people with a mental illness or with a substance use issue, but far less research about what that experience is like for those family and friends who are doing the care. We know that there is considerable strain impacting on the health of carers. We also know that over 1/3 of carers have a disability of their own, which is interesting to ponder. All of this led to our team and Sally, who her team will talk about after my presentation, looking at what are some of the support mechanisms we can put in place to better help carers. So now that we've had a look at some of the statistics of care, we'll move through 2 specific programs to have a look at some of the stories of care that sit behind those statistics. first program I wanted to mention was the Family and Friends Support Program that Melina mentioned earlier. The first iteration of this came about through the experiences of people caring for someone with an ice usage disorder. We've now expanded this program to include alcohol and other drugs. Through a series of qualitative interviews, we drew out some key themes, and this informed our program development that I'll talk with you about in my next slide. The themes, the first comment there, all comments from participants in these programs. The first goes to what was the key theme, which was about loss. Grief and loss. It was loss at a physical level, some people having experienced the death of someone they loved. More often it was about the loss of hope and aspiration, about what I had hoped for this person, be it my daughter, my son, my partner. There was also the loss of own plans and loss of sense of self for the people doing the care. And that was really key for our development of the program because we kept hearing this theme of loss of self. The second theme and the second quote there relate to stigma, which both Tom and Melina have mentioned earlier. And people, and particularly this was the case with the substance involved of ice, people didn't want other people to know about it. They were ashamed, they were embarrassed, and so they often kept things to themselves, leading to the third quote, which was those feelings of isolation, where some people felt very supported, both through health services and also through friends and family. There were a lot who felt they had no one they could talk to. The fourth finding was about meaning making and story, and that's why I wanted to share some of the quotes with you tonight about people's stories. Participants spoke to us about their reasons for involvement. They were all altruistic. They wanted to share their story because they thought it would help someone else. They also were able to make meaning of some of it themselves from sharing their story. One participant, I remember saying to me, "This has been helpful, just being able to talk to someone who isn't judging me." So I think it's really important to remember that. This is the program that we developed that I just wanted to put up briefly a screenshot. This is what we did with the information. We developed 4 core modules, which is the Family Friends Support Program, and then an additional 7 skills-based modules. Based on premise of cognitive behavioural therapy, mindfulness, about values, and then working on what are some of the skills that you can build up to enable you to better cope with what we saw as a kind of a navigating the seas metaphor. The next program and project I wanted to briefly touch upon is the Mark Hughes Foundation, and that's one that we've been working on with Hannah, who is part of our team and will be joining us for the panel later tonight. What we've learned from, again, through interviews, survey, is a sense that brain cancer is a family disease, and this is backed up by research. It's predominantly outpatient treatment, and sadly there is a quick progression. The research shows that the mental health of the carer can often be worse than the person with the diagnosis in this particular illness. The second quote there again attests, like with the family and friends research, to grief and loss. This is about the carer being in it, about being enmeshed, and that's subsequently why I chose the title of Carers in It, not with it. Some carers are so enmeshed in the process that it's very difficult for them to separate and find some time for themselves. And then the third quote there is also about meaning making, but there's a sense of hope, but also a sadness, a melancholy about why did it take this awful experience for us to reevaluate some of our priorities. And this also, again, with the FFSP work that we did, showed people's reasons for involvement were altruistic. And often their meaning making was because of the purpose that being involved in the research has given them. We know that less than 5% of national cancer funds are attributed to brain cancer, so fundraising is a big motivator for a lot of the people involved in the Mark Hughes Foundation. Just briefly, our overall findings, or consistent findings between those two programs and others, participants found it hard to prioritise their own needs, and that's really important work to continue progressing. Participants wanted to help others, and it's always also a reminder of the importance of story. Sometimes we can underestimate the value of sitting with someone and listening to their story. We don't always have to do something. That is doing something. And there's also evidence there to further explore some of these mediums of working with people to help with issues of stigma, of isolation, of lack of access to resources. And just to finish, soon, in case you would like to be involved in some of our projects, and we'd love you to be, we're going to be recruiting for 2 new projects, one of which is prescription opioid usage, which we know is on the increase in Australia. And our second one is a program called Shade Plus, which is a Suicide Prevention Australia grant for Australians 60 plus with depression and alcohol usage. So we've got some contact details there if you would like to get in touch with us or about anything else that's been raised tonight. So thank you for your time.
Thank you very much, Dara. So I'd like to introduce Dr. Sally Fitzpatrick, who is a developmental and clinical psychologist and conjoint senior lecturer at the University of Newcastle. So Sally is very passionate about understanding the factors that contribute to mental ill health and helping the well-being of Australians. She's currently the acting programme manager for Everymind, which many of you will know is a leading Newcastle-based institute dedicated to the prevention of mental ill health and suicide. So Sally will be sharing with us, I hope, some important tips and advice on how we can look out for those who are involved in caring for their loved ones, the parents, the family and friends who provide the support and care for people with mental ill health before and during the treatment, and as we've heard from Lena, maybe sometimes even when treatment is not adequately available. So, Sally.
Thank you, Tom, and thank you for having me. Everymind is genuinely thrilled to be able to present here tonight with our colleagues from the university and from HMRI. As Tom said, Everymind is a national institute. We are based in Newcastle, but we are very much focused on the prevention of mental ill health and suicide. And we've heard a lot about mental health already tonight. We've heard that it's prevalent in our communities, that COVID has certainly exacerbated the impact of mental health, ill health on all of us. And we've also heard that more than half of those who experience mental ill health don't seek treatment. This means that our loved ones, our families and our friends provide most of the support and care to those in our lives who are feeling worried, who are feeling low and who are struggling with their mental health and their mental ill health. But what does that mean? Let's just take a minute and have a look at, when we talk about mental ill health, what are we talking about? Some of the signs that you might recognise in family or friends that you're supporting include things like withdrawal. They start to lose interest in activities that seem to really be enjoyable previously. Their work output changes, their motivation levels drop, and their concentration levels might change. They might find it difficult to make decisions that they previously didn't find difficult, or even finding solutions to problems. Their mood may change, their energy levels may change, their sleep may change, they may find it hard to fall asleep or stay asleep, and eating habits change. And they may start using substances or drinking more alcohol than they previously have. But it's important to remember that one of these signs by themselves doesn't mean that you're going to meet criteria for an anxiety or depression order. disorder. What we're really looking for are multiple signs, or that these signs continue over time, they increase with severity, and at those times we're going to want to have a conversation with people in our lives about what's going on for them. But this is hard. Providing support and care for those in our lives experiencing mental ill health is not easy. So if we start at the bottom level of the circle, what we can see is that the care receiver and the caregiver are crucial in the way that this support is given. I'm using the term caregiver just for ease of reference and for readability, but I'm really talking about anyone that you provide support to around their mental health, and that may be providing support around physical needs, social needs, psychological needs. The relationship we have with the person we're supporting is really, really important. Don't underestimate the positive impact you can have by asking someone if they're okay. How are they doing? How are they coping? Listening to them, asking them what you can do to support them, and maybe listening to what they want rather than problem solving for them. The benefit of listening cannot be underestimated. But you might also notice that mental ill health starts to impact others in the family as well. It may not just be the person that's experiencing the anxiety or depressive symptoms. Children are the classic examples here, and sometimes what we might need to be able to do is talk to children and explain what mental ill health means to them in a language which makes sense to them. As a clinical psychologist doing therapy, I never use the words anxiety or depression with my clients, my child clients. That's not appropriate. What you want to do is find words that are appropriate to them. So children will often describe anxiety as butterflies in the tummy, shaky hands, or lots of thoughts in their head that they can't stop. When you start using the words that you hear children talk about, you can then initiate that conversation with them about what their experience is like of the person that you're supporting. But mental ill health can also impact our social networks. Again, we may find that people may not understand what's happening and know how to help, and therefore the person you're supporting wants to withdraw. Or you may find from your caregiving responsibilities that you don't have access to the people that you normally would have. It can be too hard to do it alone, and sometimes we need support. And when that disappears, that can also impact on us significantly. And finally, the role of service providers, government policy and community attitudes can have a really big impact on whether mental ill health is facilitated in a positive way or whether it reduces help seeking. So at Everymind, we've spoken to carers about their experience of providing support to people. We've looked at the research and we've talked to service providers. And overall, what we've found is that providing support to someone can have an impact on the carer themselves. They may experience a reduced quality of life, not achieving the things in their life that they would otherwise like to be able to do. Their own mental ill health may be impacted. We know that carers tend to have higher levels of anxiety and depressive symptoms than the general population. We know that they experience financial pressures, that you may find it difficult to be able to go out to work or maintain a job, do the hours that you want to be able to do. We know that isolation and social support reduces. We know that stigma is involved. It can be really hard to talk to other people about the person in your life that you're supporting. And that means that for that person and for you, it's hard to find help. And carers talk about not having a lot of time for themselves. But we know there are things that we can do. We know overall that if we develop coping strategies with carers, their mental health, their well-being all increase. And we do that by building their self-efficacy. So self-efficacy is our self-belief in our capacity to do something. If I believe that I have the capacity to cope in the face of adversity, I'm more likely to do that. But if I also strongly believe, or alternatively, if I strongly believe that I don't have the capacity and that I will crumble, then probably we're going to have more experience of mental ill health. We know that the relationship with the care receiver is really important and we need to strengthen that. We know that we need to strengthen social support and connectedness, and we know that carers absolutely want to be included in care planning for the person that they are supporting. These are all the sorts of things that we want to build into any program that we develop with carers. So how do you know that the caring experience may be impacting on you? What are the things that you might start to notice? They're very similar to the sorts of things that you might start to notice in the person you're providing support for. You might notice that there are some physical changes in your body. You might be more tired, your weight may change, or have other health issues come up. You might be slightly more emotional. Your anxiety levels might be increased. You might feel more sad, teary, or have a short fuse. You might start to self-blame. What did I do wrong? What can I do to make it better? Take on the responsibility for yourself. Or what we find carers do is really think about, if the person I'm supporting, if only they would change, things would get better. We know that if we can work with carers around their work experience, things are likely to improve, and changes in relationships may impact on you. So as a carer, we encourage you to be informed. Find out what anxiety and depression means. Share the responsibility if possible. Don't take it all on yourself. It's very hard to be able to really support someone if you are the only person doing that. The people that you find support from may not come necessarily from your family or friends. They might be from other carers. Accept care from yourself. Make sure that you connect with people. Find what grounds you and actually do it. If you know that you enjoy something as simple as a cup of tea in the sun, find 5 minutes to do it. Be kind to yourself, especially in 2020. This is such an unusual year and such a difficult year. We absolutely need to recognise that we're not going to hit all the standards that we set for ourselves. That's actually okay. Looking after yourself is not selfish. At Every Mind, we've developed the Minds Together for Carers program in response to all of the issues that I've been talking about. This is a program, an online e-health program designed in collaboration with service providers and with carers. Carers provided the information and the voice for this program. And what it aims to do is address each of those issues that I've talked about: improving knowledge for carers, increasing their self-efficacy, empowering them to manage symptoms themselves, support their families, connect with others, and also provide connection if crisis occurs. The final thing that I just wanted to let you know before I finish tonight, because I know that I'm completely out of time, is for carers in Hunter, New England. This is Carers Week, as Dara said, and we are running an event with a couple of other local organisations in the Hunter, encouraging carers to look after their own self-care. So what we're asking carers to do is to submit photos of their self-care activities during this month to help raise awareness of the importance of mental health and wellbeing. Carers that enter the competition have the chance to win a personalised relaxation pack valued at $100, provided by One Door Mental Health, and the winners will be picked out at random. So if you are a carer in the Hunter, we absolutely encourage you to be able to connect with other carers through this means. The other thing that we will do at the end of this seminar is ensure that our support services are put up so that you can access information if any of the information tonight has been problematic, has triggered a response for you, or you want to seek support for the people in your lives that are important. And we'll make sure they go up again at the end. Thank you.
Sally, thank you very much for that. And I'd like to thank Sally and Dara and Melina for their presentations and for the time and they've put into preparing their presentations and coming here to talk to us tonight and to share with us their insights. But now we're going to share those insights with you a bit more and explore them a little bit more. So I'd like to ask the presenters to come up on stage here. So if Melina and Dara and Sally can join us up here for the Q&A session. And we have two more people joining the panel. So I'd like to welcome Professor Michael Breakspear. Michael is a psychiatrist and a neuroscientist, a professor of systems neuroscience at the University of Newcastle. His work focuses on understanding major mental health diseases, including mood disorders, schizophrenia, and bipolar disorder. And I'd like to welcome Hannah Coates, who's a project officer at the University of Newcastle, who works closely with Dara at the University of Newcastle's Priority Research Centre for Brain and Mental Health. So we've got a number of questions. I'm going to start off with some questions that were pre-voted, but I hope there's a whole series of them coming in. We'll take some time to address as many of these as we can. If we can't address them all, we'll try and come back to you with responses individually perhaps, or address them online at a later point. So I'm looking for the questions. Got them all as well. I was worried for a moment. It is 2020. Something's going to go wrong at some point. So, all right, here's a topical one. During COVID-19, mental health professionals withdrew patient support. What can patients do, and maybe what their families can do, when this support is not readily available?
Yeah, Tom, I might answer that one if that's okay.
Yes.
I absolutely think that during the COVID-19 pandemic, and the social distancing measures and the lockdown that some people in the country are still going through, I think that has presented some absolutely significant challenges for people needing to access mental health services. And as I mentioned in my presentation, I do think that e-mental health interventions and e-mental health services offer one possible option for people who are needing to access services but can't access traditional services during that time. And something that I thought was probably worth mentioning is that in response to COVID-19, the Australian government has actually introduced a new temporary Medicare benefit scheme that enables people to access Medicare rebated health services via telehealth during COVID-19. And by telehealth, I mean using video conferencing technologies like FaceTime or Zoom or Skype that health providers can use to connect with people in real time about their health care. So I just wanted to mention that if you do want to access that scheme, people can visit their GP or call their GP and get a better a mental health treatment plan. So I just thought that might be worth mentioning for people who are struggling to access traditional mental health services during that time. Yeah.
Michael? It's an important question, but I work in private and public practice, and I think it's important to also say that I don't think mental health practitioners stepped back. We all pivoted as much as possible to practicing psychiatry or mental health provision safely, either by telehealth, as Melina just suggested, or using social distancing if face-to-face was permissible. I think what happened is that people didn't want to go into hospitals and access a whole range of medical services, including mental health, in person, because they saw hospitals as a place for exposure. And hospitals have done an enormous amount of work, as have all other health services, including mental health services, in continuing to provide mental health in a safe, COVID-safe sort of forum. So we should really encourage people, as well as accessing online and telehealth services, which are really laudable, but to continue to, where safe and possible, to reach out to the face-to-face services, GPs, and psychologists and psychiatrists are still doing mental health service, and to sort of push back a little bit about the notion that we're not out there providing the sort of health services that we need now more than ever.
Thank you, Michael. I think you're describing a universal issue for lots of people during COVID, not just in relation to mental health, but lots of aspects of physical health as well, that they've hesitated to come forward to seek care because they're afraid of exposing themselves perhaps unnecessarily to the risk of COVID. So I'll move on to the next question, which is, what is the relationship between healthy lifestyle and mental illness?
Tom, I think just going back to Melina's figures around, if we're looking at perhaps 45% of the population with a mental health issue, I just wanted to, I guess, emphasise the spectrum within that, that we have people who will experience psychoses, the more severe mental illnesses, And yes, it can be very challenging for someone to feel motivated then to exercise, as it can for people without a mental health issue sometimes, to control diet, to cease smoking, and that's absolutely an issue. But we have a lot of people who will have one, maybe more episodes of being unwell mentally, but actually function very well at other periods of time. So what we do know for people, I guess, with a mental illness or without, there are certainly some things, and lifestyle, diet, activity is certainly one that is a protective factor. Some of the others are about connection, about communicating, about living a life that's true to our values. A purposeful life is often spoken of, and I think often more helpful than a happiness life. How we, as I said, how we can connect with others, how we can have a good work-life balance is quite important as well. Sleep patterns. So yes, absolutely healthy lifestyle. I think of it in that broader spectrum about an emotional and psychological healthy lifestyle too.
Michael, quickly, if you can, we've got questions to get through.
Yeah, I think there's been a real revolution in mental health services about bringing in physical health, physical wellbeing, and I personally can't get enough of it. I get all my patients to be as active as possible, and we might come back to this. And you just require, at the very least, 30 minutes of getting your heart rate and your breathing rate up over what we are doing here sitting down. And it's a lot more achievable and obtainable than I think a lot of patients and a lot of us in mental health services appreciate. So I'm very enthusiastic at prescribing physical activity, I call it, not necessarily exercise, because that can often put people off, but 30 minutes of physical activity a day, tailored to the person's interests and engagement and capabilities. And there's really strong evidence for dementia, for depression, for anxiety disorders, for sleep, that sort of activity is very beneficial.
Thank you, Michael. So I'm going to turn to a couple of questions about helping young people. So, first question is, what support can we provide to young people in our community when it comes to self-harm?
I can take that one, I think. I think going back to what Sally spoke about in her presentation, with both issues, the first thing you can do is improve your own self-efficacy and learning everything you can online. Places like Beyond Blue and Lifeline have fantastic online supports that can give you the information you need to support people. I think it's important to recognise that self-harm is a non-verbal expression of an emotion, and it's a coping mechanism. It's not a healthy coping mechanism, but it's about linking that person in with support so that they can develop healthier mechanisms to deal with what's going on inside. And I would say with bullying, something that's really important is to, again, find a way to get them the social support if they're not getting it at school in other places. So there's places like PCYC, for example, that you can link them in with. And then places like Beyond Blue also have fantastic online spaces that are clinically moderated and that you don't have the issues that you find on Facebook or Instagram. Yeah.
Thank you. Well, that leads into the second question, which is, does the use of social media increase depression or anxiety in young people? I feel bad saying this as we're out in social media here ourselves, but I'm interested in your thoughts on this.
So I think I'm the one who's left to start, so I'm going to. I think people will be surprised to know that the research probably goes in a direction against what the media says. So we hear a lot in the media around social media is really bad for young people. We need to get them off social media. It's going to cause anxiety and depression. The research doesn't support that. The research certainly says that social media can be a really positive experience for young people, but it's not as simple as it being good or bad. We need to think about the context. How long are young people spending on social media? What are they doing on social media? Who are they contacting? Is the experience that they are having from their perception positive, negative, or otherwise? Do you know who they're talking to? Young people are socially connected, much more than my generation was ever going to be. We can't remove that from them. That is something they're going to do. What we want to do is facilitate that, and most young people will use social media in a positive way. It doesn't mean that there's not problems, but I don't think the research doesn't back up that social media is the link to anxiety and depression for young people.
I would just completely agree there, I would say if having a dialogue, we spoke about stories and dialogues before, rather than shutting down social media, which can lead to it being used in a subversive way by young people, encouraging a dialogue with your children or your peers about their use of social media, helping them self-regulate the amount of social media exposure, and also, just as we spoke a moment about bullying through social media is similar to bullying in the schoolyard, and teaching social media literacy and bullying literacy and other harmful exposures.
Thank you. So I guess there's always, every generation there's been a sort of a moral panic about something. And whether it's television or radio or rock and roll or whatever, and the moment social media is it. So I'm reassured about what you've had to say there. But let me move on to the next question, which again relates to a question of our times. That there are an increased number of aged, disabled, divorced, separated, and people living alone in our communities. And with this often comes lots of mental health issues. So we're interested in hearing from you about how families and others can become better at identifying people who are isolated like that, and at supporting people who are living alone and isolated socially and in other ways.
I might start with that one, Tom. I think it's a really interesting question, and I think it's interesting because that sense of living alone is often viewed as negative. I think what we really want to do is understand the perception of the people that we're wanting to support. For a lot of people who may have a disability or other challenges in their life, living alone means independence, and that's something that they want to be able to facilitate and foster. What we want to do is have those conversations with our loved ones, our friends, to see what their needs are. Does living alone equate to loneliness? And we know loneliness in the research is one of those really key issues which is coming up more and more associated with mental ill health. So we want to work that out first. Once we've done that, what we want to do is be really creative in the way that we can respond and support those people who are living alone. And I think COVID has taught us an awful lot around how we can do that in ways that we never thought we possibly could have. So we can do it through social media. We can do it through telephone calls. We can be creative in what we do over those contacts. They don't necessarily just need to be talking. I often watch the footy with my dad, who lives in an aged care home in South Australia. That is something we can do together, even though we're so far apart. I think we can find creative ways to do that, but I think we also need to be able to connect with other people to support us. If we do have someone in our life who is experiencing mental ill health as a consequence of loneliness, pull in other people to support you to make that connection with them as well.
Thank you. So almost the last question, and this moves on to treatment, and it's particularly in relation to what's available when currently available medication side effects outweigh benefits. So this is often a barrier to people staying on medication long term. What can other forms of therapy, psychological therapies or whatever, how can we minimise the side effects and encourage people to get the benefits of medication or consider other therapies?
Well, I prescribe a lot of these medications, and once again, I think there's been a massive movement in mental health service provision, psychiatrists and others, to identify that weight gain seems, or metabolic syndrome seems to be a very problematic side effect in some of our otherwise most effective medications. So for me, I'm talking about this before I prescribe a medication, and I give my patients the choice and the knowledge up front, the type of behaviours that the medications can cause that then lead to weight gain, such as snacking and topping up with second courses, looking at exercise, looking at referrals to exercise physiologists, referrals to nutritionists, and giving people a range of options so that if the medication early causes weight gain, we can do something about it before there's considerable weight gain that then becomes a problem in its own. And if it's required, sometimes we do look at adding medications that specifically manage the weight gain, and this can be medications that otherwise are used in diabetes, and not waiting, leaving patients in the dark and waiting for the weight gain to occur, which is what was happening 3 to 5 years ago. But I think we've pivoted a lot away from that, I hope, universally.
Thank you very much, Michael. So I have one last question, and it's kind of something we've been talking about around all night, which is around how the pandemic has caused mental illness in the community. What's the impact of the pandemic, which Australia has fortunately been mostly spared compared to other countries? What's been the impact of that pandemic on mental health in Australia?
I know a little bit about this, but I feel like I'm jumping in too often here. I think the impacts are direct and indirect. First of all, they're making some of the risk factors for mental health illness worse, and we spoke about those: loneliness through the shutdown, unemployment and financial distresses. These cause depression and anxiety outside a pandemic, and we know they've become quite a lot worse during the pandemic. Thankfully, not as worse as they might have otherwise become, and we also have hope as we see pandemic numbers coming down in Australia. Secondly, there's a lot of uncertainty about acquiring the illness, or a loved one acquiring the illness, or just a general uncertainty about the future, about the world economy. So surveys in Australia, and their surveys for up to 8,000 people, show a doubling of mental health problems, broadly defined, and a doubling of concerns about all of those things: unemployment, loneliness, financial concerns. In this survey, virtually no one out of the 8,000 endorsed feeling better during the height of the pandemic. We've, as you mentioned, more or less contained much of the pandemic here in Australia. I know people in Melbourne are still doing extremely tough. And we've also created, as Melina mentioned, the telehealth provisions in Medicare for telehealth. It's so new, and it's really unknown about what are the longer term effects. But as these risk factors go up, we will inevitably see depression going up, and there's also obviously concern about rates of suicide going up. And that's why it's so important to have good policies, government policies, to support people through the pandemic. And I'm sure we all agree we shouldn't be stepping back at the moment. We need to support people until we get people back into work and back together again.
Thank you very much. So I'm going to stop the questions. There's lots more I'd like to ask. I'd like to ask more about, for instance, how you manage your mental health when you're quarantined, perhaps unwittingly, but that's another day's work, and there are lots more questions that we'll try and find answers for and put them up on our website over the course of the next few days. So I'd like to thank Dara and Hannah and Melina and Sally and Michael, and let you all stand down. Thank you very much this evening. So we've one more speaker. Our aim is to finish shortly after 7 o'clock, and I'd like to introduce you to someone who is very special to us at HMRI. He's been a great supporter of HMRI for many, many years. He's a former chair of the board here at HMRI, and he's been a great community figure here in the Hunter, and that's Glenn Turner. Now, a few years ago, Glenn undertook a personal as well as a fundraising journey, the 3D Healing Walk, which went along the historic Via Francigena. And I've never even heard of the Via Francigena, so maybe Glenn's going to tell us a bit more about that. But basically it starts in Canterbury in England, works its way through France and Switzerland and Italy to end in Rome. And the 3 Ds stand for depression, dementia and diabetes. So Glenn is going to share with us some of his journey and his relationship with HMRI and why he's been involved with us so well for so many years. So Glenn, over to you.
Thank you, Tom, and good evening, everybody. Why do I support HMRI, and why should you? Mental health research is a remote concept that comes to us by circumstance or age. Age brings a realisation that the bulletproof vest of youth has deteriorated, and a far wider cohort of family, friends, colleagues increasingly impacted by diminishing mental health. Additionally, we now live in a very connected world with instant communication and vast data. References tonight to e-health, digital intervention. We have shortened cycle times in everything in our life. It's become a pandemic. In baseball terms, whereas 30 years ago we were in the stand watching a game, we are now all on first base. We are not watching the game anymore, we are in the game. Social media, we know so much more. So what is my story and why do I support HMRI? I wrote down 7 things that came to me when I was asked to do this. Alan Jones, the surgeon of Crowthorne, Proverbs, Above the Neck, 3D Walk, Tony Abbott and angel investing. In the 90s, I remember Alan Jones driving a crusade to get rid of the stigma about mental health. He is still crusading for it. So I take my hat off to Alan for what he did, because he started it from my perspective and he continues in it. He dragged this issue out for me, removed the stigma. Surgeon of Crowthorne, a great book by Simon Winchester about the construct of the Oxford Dictionary and the extraordinary contribution by a professor who was interned for life, for murder, and it was regarded in those days as insane. It's a ripping yarn, but posed the question for me, did he have a mental illness? Proverbs for all occasions. I practice mentoring a number of business people. I do it all from a little book of Proverbs and sayings, which I have. Home truths. They're all ages. Things like, the only thing that grows when you share it is knowledge. Check twice, cut once. What gets measured gets done. This too shall pass. Nothing ventured, nothing gained. Innovate or evaporate. Healthy body, healthy mind. References to that tonight. 30 minutes a day exercise. Above the neck. When interviewing for Tom's predecessor, Professor Michael Nilsson, I was very focused in my discussions with him on what I called above the neck as a frontier not yet breached. I was and remain fascinated by the brain and its power. Think Stephen Hawking. Think the mystery of it all. What causes compassion? What causes other emotions in us? Tom mentioned the 3D walk. Yes, it was a walk to draw attention to depression, diabetes, and depression, and dementia. It turned out to be a great experience. I walked for 66 days, 30 k's a day. I lost 14 or 15 kilos. I had a great time. It was tough at the start, but raised $100,000, which went to depression and dementia studies. It was used to raise money, but great sense of accomplishment, and I don't think I really understand what mindfulness is, but I had a lot of time to think. Tony Abbott. On my walk, when I was walking, I learned of the establishment by Tony, then Minister of Health, of the Medical Futures Foundation. I simply and spontaneously dissolved in tears at the wonderful opportunity this created for Australian research and researchers. I was literally euphoric. I've toned down a little bit, but it's real. This fund has started. And then angel investing. Well, since 2007, I've become involved in angel investing, including some investments in medical research technologies and therapies. Wow, this defines patient capital. You have to wait a long time. There is no return from early stage research. So you have to depend on contributions from the community, the government, and those that are in the business of providing this. Which is why, and the other good thing about angel investing, the deal flow of what's coming, the kinds of technologies and the spread away from the strictly laboratory-based physical health type things into now the social side, the other side of the brain, mental health issues and social issues, also important. But this is why HMRI and mental health research needs you. Because we need your donations. I went online before I came here and it took me 1 minute 46 seconds to make a donation to HMRI. Within 22 seconds I had a confirmation on my email of it. So in 2 minutes 15 seconds or something like that, it was done. It was that easy. Finally, HMRI is of the community. It was born of the community, it's supported by the community, and it's growing through the efforts of all. It's chaired by the community to ensure we reflect community priorities, and it flanges together the traditional research capabilities of our wonderful University of Newcastle here and the clinical capabilities of Hunter New England Health. And it's nimble. This is our town, and this is our HMRI. Your support is terribly easy to effect. So I'll leave you with my favourite proverb. A merry heart is medicine for the soul. There's another bit that says, but a broken spirit drieth the bones. Thank you.
Thank you very much, Glenn. And thank you to all our speakers tonight for sharing their experiences and their knowledge with us. I hope we've all gained a better understanding of some of the issues affecting people suffering from mental health issues and the support that their carers need. And there'll be a list of resources available on our website and on Facebook feed, so you can access the support you might need arising from the topics discussed today through those. So we hope you've all enjoyed watching this virtual seminar. As I said earlier on, it's the last one of this year. We will be back again next year. I think this format's worked really well. And on behalf of everyone here at HMRI and our partners, the University of Newcastle and the Hunter New England Local Health District, I'd like to thank you all for joining us and for your interest in our work. You can keep up to date on all our latest activities and work through our website and through social media channels. Our community seminars, they'll be back next year. And if you want to know more about how you can support in any form our life-changing research, please don't hesitate to get in touch with us, either online or by phone. We always love to hear from the community, as Glenn has said. So we look forward to catching up with you again, either in person, hopefully in better times, or virtually, which has worked so well for us over the past few months. Thank you for your time. Enjoy the rest of your night. Stay safe and stay well.